well, I also want to thank the organizers, Philippe and Marie-Louise, for organizing this very interesting group of papers. I've gained a lot already from the first two papers. I know I'll gain a lot tomorrow. When Philippe invited me, he said that he would like me to present something, but the problem was I don't have a completed paper, even a working paper, on a relevant topic. I do have a work in progress, so he said, well, you can just talk about that or whatever you like. So my, is that what he said?
Yeah, I knew it would be interesting. As long as you're not talking about hockey, it's okay.
Yeah, don't worry, I have nothing to say about hockey. Except go Leafs, go. So, so my talk is broken up into two parts, and I was going to do the first part first, but I wasn't sure that was right. But then after David did such a terrific job of reviewing the relevant literature, which included one of my papers, which I will talk about, but also did a terrific job presenting his work, I think it's easier for me to do the more technical part of my talk first, and I'll go back and talk about general issues, which are challenges to personalized medicine and where economics can maybe shed some light. For me, it's something to think about as I do further work in this area. Just what problems should I tackle? Should I maybe get out of the business of personalized medicine and go back and do other research or whatever? So that's how the talk will progress. So unfortunately, I don't have my title page up there, but it's not very interesting, I guess, anyway, so it doesn't matter. So, when I think about the economic research on genetic testing and insurance markets, I think about two phases. So the first phase was about equity and fairness, and I spent quite a bit of time thinking about those issues and have written probably way too many papers on that topic. And I think that the essential question there is, should insurers be banned from using genetic tests? So I'll talk about that a little bit, and I think that almost everything that needs to be said about that has probably been said, but it's still a controversial subject. So, and I think that Anya Prince tomorrow will help us understand why it's still a controversial subject. And for economists, certainly we don't all agree on whether or not there should be a ban. I, for example, think there should be a ban, but I could be easily convinced otherwise in 10 years' time, and I'll explain why. So, I think the more important question now is to move on to research phase 2 and say, how do we make effective use of genetic information, given that we know that it creates some social problems, or at least in the minds of some people, some social problems. And I think that what is really quite important is that we think of more sophisticated use of policy instruments and mandates, et cetera, for health insurance. So to ban or not to ban, why is the question still controversial, even though there's been lots of research done on it? Well, I think it's because there are competing conceptions of what's fair and what's right in society. And for economists, that is how we think about welfare. Do we just think about efficiency considerations, or do we try to roll that into, let's say, utilitarian social welfare function analysis, which I like to do because it embodies both fairness and distributional concerns. But also there are competing predictions of market implications. So if you think that there have been some recent arguments why the Rothschild separating pair of contracts might even exist in an equilibrium where there's a very small fraction of high-risk types in the population. If you believe that, then you have a very different view of the implications of a ban than if you think that we're in a Wilson-Miyazaki-Spence separating cross-subsidizing equilibrium or pooling equilibrium due to Wilson. And I'm not sure, I'm not sure there's been very much empirical evidence that we're ever in a Rothschild-Stiglitz separating contracts kind of equilibrium, but it's not clear what we're in, to be honest. We're not necessarily in Wilson-Spence-Miyazaki cross-subsidizing equilibrium in the real world either. So to think about the idea of whether or not you should ban genetic testing or any particular characteristic which is predictive of risk type, people often think about the problem of reclassification risk. Well, for genetic tests, there really is a possibility of reclassification risk for most individuals because we don't know that much about our genetic type. And so in the future, we might be worried about now that in the future will turn out to be a bad genetic risk from the insurance point of view and have to pay a high premium. So people don't like premium risk or reclassification risk. And that may explain why, if you have a survey of individuals in a population, like there have been surveys both in Canada and the United States, where the fraction of people who think that insurance companies, like life insurance companies, should not be allowed to use genetic test information is like 90%. And even when you say, well, what if there were some price implications, you still get a very high fraction of people saying, no, it just doesn't seem fair or right, where they might actually be thinking of, gee, I don't want to end up being one of those poor high-risk types who gets charged a really high price for insurance. So if you think about that problem in the context of a simple Rothschild-Stiglitz model, and so I just put it up here, but everybody knows pretty much everybody knows, I think, what that model is. Then if you just look at the last bullet point, it's an interesting question to ask, well, does initially everybody know his or her risk type? Or does initially everybody think they're the average risk type? And the truth of the matter is probably somewhere in between, because if you have family history of certain diseases, then you know you're more likely a high risk type than a low risk type. And those sorts of models haven't been exploited fully, although Ricard has a paper how people learn a bit about their risk type as life goes on, and so okay, I'll just give you the stark two cases where everybody knows initially what their risk type is, and then the case where people don't know initially what their risk type is. And I'll try to show you my argument for why I think there should be a ban on genetic testing, if you don't take into account the fact that, well, wait a minute, there are some uses that genetic testing could have, and maybe that should be, maybe that'll dominate the equity arguments. So suppose everyone does know his or her risk type. Well, then, if you allow risk rating of a laissez-faire system, then everybody will be charged their risk type specific insurance price. Everybody buys full insurance, so there's no inequality between people who have losses and who don't have losses. But of course, you notice that the high-risk types are worse off because they have to pay a higher price for insurance, whereas the low-risk types are better off because they pay a lower price for insurance. So these spikes are suggesting that about a third of the population is high risk and 2/3 is low risk. The truth of the matter is, in terms of genetic information, probably the fraction of people who are high-risk types is more like 1% to 5%. In the current world we live in. So if you have a ban, the problem with a ban is then, well, what's the equilibrium concept going to be? Well, suppose it's the simple Wilson pooling equilibrium concept. Then the insurance companies want to attract the low-risk types, so they offer the quantity of insurance that the low-risk types would most like. From the low-risk types perspective, the pooling price is a little bit higher than their price, their actuarially fair price. And so they want to buy less in full insurance, so that's what the insurance companies offer. That's David explained very well. So if that's the case, then there is going to be some inequality. There's going to be inequality between the people who have losses because they're not fully covered and the people who don't have losses. But if there's a small fraction of high-risk types in the population, it seems pretty obvious that the fraction of insurance coverage will be very high, and I've done some simulations on this using, well, I'm going to put in scare quotes, data. It seems pretty high in most believable scenarios, I would argue. And so, although there will be some inequality, there's less inequality, and you end up with a distribution of income, which is basically net income after insurance prices, which is a mean preserving contraction of what you would get with full risk rating. Now, suppose everyone is initially uninformed about his or her risk type. Then if people buy their insurance early in life, they will buy full coverage based on the actuarially fair pooled price. And once they find out whether they're high or low risk type, if they're charged the risk type specific price, they will not buy or sell reinsurance. There's a famous Milgram Roberts, well, it's Milgram somebody, a no recontracting theorem, which shows that you would recontract after you get new information in this kind of environment. And so here, people will just buy long-term coverage or full coverage, guaranteed renewable insurance, and the market will solve the problem, and there will be no inequality caused by the risk differentiation. But the problem with that, and I've got a couple of papers thinking this through with various co-authors, the problem is, when do people buy their guaranteed renewable life insurance contract? Not at the date of their birth. Nobody does that. Parents can buy life insurance for their children at the date of birth, and I'll bet I'm the only one in the room who did that, because I've been worried about this problem for so long.
You should have told us earlier.
Yes, I should have told you earlier. But I realized by the time my first child was about 3 or 4 that the actuarial terms or the price was way too high. So I liquidated the insurance policy pretty quickly. But to my credit, I gave the money to my kids. So, well, maybe to my credit, to my foolishness, I don't know what they spent it on.
Excuse me.
Yes.
I will have another baby in July, and I bought an insurance extension for insure pre-existence.
Wow.
So
There's 2 of us, yes.
yeah, now it exists.
Yeah.
But you will sell it in 3 years.
I was holding mine, yes. So, so if you start thinking about, well, how do we measure the effectiveness of guaranteed renewable insurance? Because it is somewhat effective in reducing premium risk. But to measure how effective it is, you have to decide at what age of an individual you want to consider your base age. And so should you think about it at birth, date of first insurance contract, age 45, and people are between 25 and 35, people start buying life insurance, and there's a nice curve which shows how quickly that goes up. So I don't think the private market can necessarily solve that problem. And in fact, in the first paper I wrote on this with Matthias Colborn and Ashley Stanley, we showed that in a horse race, banning genetic testing is actually more effective, or banning certain types of information is more effective than guaranteed renewable insurance when people buy it before they know their demand type. In other words, how much demand am I going to really want? When you're 25, you don't know whether you're going to want $100,000 life insurance coverage when you're 50, or whether you're going to want $400,000. You don't know how your marriage is going to go. You don't know whether you're going to have 1 or 2 or 3 kids, or the taxi driver who brought me into the city told me he had 10 children, ranged between the age of 1 and 21. And I wondered when he knew he would have 10 children in that age group. So he should have a lot of life insurance. I suspect he doesn't. So, how should economic research progress in the context of what I've said so far? Well, a lot of examples have been individual disease specific, but maybe we should start thinking about it in a more systemic way, like think about getting data which groups all genetic diseases and look at the aggregate amount of information people know. There is a guy who's doing that, an actuary named Angus MacDonald. He's a very sensible actuary, unlike many of the other ones I've run into. And he thinks that he's making progress on that. And, well, there's a whole bunch of more things. I had modeling institutions, and then I realized what Dayton was going to talk about, modeling physicians, how they use it. But the most important point here I want to mention before I get back to before I get to the model, is that we shouldn't, while we're doing our research on health uses of genetic test information, we shouldn't forget about these spillover effects. Because once individuals get a lot more genetic information, that is going to tend to spoil the life insurance market. It'll either spoil it in the presence of a ban because of adverse selection inefficiencies, or if there is no ban, then it'll create more premium risk in other forms of insurance. So although the implications for better health insurance and health with genetic information may dominate all that, I don't think we should forget about it entirely. Right. So, thank you, David, for actually presenting your work, because my work with Lilia and now work in progress with Wanda Mimra was well, at least partly explained in your model. We have very similar models. Most of the models in this area are similar. And I'm pleased to see that there is a lot of research now going on where people are taking self-protection and self-insurance considerations, which are valuable in light of genetic information into account. And most of the papers here are moving in that direction, so that I'm happy to see. What I'm a little bit unhappy about, even with myself, is that there isn't much work on this for public health systems. Most of the work, we love working with private insurance markets, but how many countries really have fully private health insurance markets which are unregulated to the extent that it makes sense for us to talk about these as Rothschild-Stiglitz equilibria or Wilson-Spence-Miyazaki equilibria. Just south of the border. And some people would say they deserve the healthcare system they have. We shouldn't worry about it and try to help. We should try to help public health insurance schemes do a good job with genetic test information. Having said that, the paper that Wanda and I are working on is a private health insurance model. But the one I worked on with Lilia Filipova is written in the context of public health insurance. And of course, there are problems for public health insurance systems with trying to effectively introduce the use of personalized medicine and make sure that you get welfare benefit from it. Yeah, I should have said if you have any questions at all, please stop me at any time, because I don't have a plan of how far I get. I get to 5:15, that's fine. So what we showed in our paper is you really need to understand the interaction of individual incentives, moral hazard and use of surveillance prevention, and the financial cost of healthcare, which arise as a result of new genetic information and the reaction that people want to have for using surveillance and prevention in a genetic type perspective. Each genetic type will want to use that differently, as David actually mentioned in his introduction. And we find that we may want to either restrict or encourage the use of surveillance and prevention strategies, and unfortunately in unintuitive ways to secure welfare improvements. By non-intuitive, I mean it's not obvious who you should be rationing and who you should be promoting to use these sorts of tests. So you might actually want to ration the high-risk types' use of surveillance relative to what they would like to have if they get to make the decision, and you would like to push low-risk types to make more use. And that is definitely not the kind of message you get when you read health experts talking about it. They always think, oh no, the problem will be getting the high-risk types to use surveillance enough and have enough colonoscopies and mammograms and so forth. So it's definitely a tricky business. I mean, it's even a tricky business how to ration or how to encourage people to have more colonoscopies per 10-year period than they want. You drag people kicking and screaming off to the colonoscopy clinic. It'll be an unpretty sight. So it turns out that you can think about all these problems, and in particular you can think about the problem of whether or not introducing a new genetic test, which will then have repercussions on the use of traditional medical procedures like mammograms, colonoscopies, and so on. You can ask yourself whether the value of that information, even if the genetic test is free, it's come off patent, in other words. You can ask that question by simply examining the curvature conditions of the value functions, both the private value function of individuals or the social value function, which is the private value function once you take into account the financial costs of delivering healthcare services, which of course individuals in the public healthcare system don't care about. And this is one particular issue which might actually lead to private health insurance doing a better job, because with private health insurance, you can have different deductibles and co-insurance on different facets of healthcare delivery, such as you could have a low deductible or a low coinsurance rate, or no deductible, no coinsurance rate on surveillance technology, on use of surveillance technologies, if that turns out to be the right thing to do. But you could have a high deductible on treatment. So if you have a high deductible on treatment and low deductible or zero deductible on surveillance, then that's a way to push people to get more surveillance, if in fact that's what the socially optimal outcome calls for. And so these are some of the features that Wanda and I are building into our model based on this original model that Lily and I wrote up. And right, so here's the basic model, and I'll try to think about try to give you some information about how we're changing it in the private insurance model. So the idea here is that everybody has a certain probability of disease. If you don't know your genotype, then everybody has the same probability of disease, we assume. But if you do learn your genotype, then that probability of disease will vary across individuals with high risks having, of course, a higher probability of disease onset than low risks. And I have in mind here both, I have in mind two specific diseases, breast cancer and colon cancer. And I'll talk a little bit about testing for those two diseases as examples. Oh, and that's another thing I want to say. We need more examples in this literature. And there's very little information done even by the clinicians and the scientists trying to figure out how this is all going to work out in real life. So I have a slide on that later I'll emphasize. So, depending on your level of surveillance, which is S here, the higher level of surveillance means you're more likely to detect the disease early than late. So, our probability of early detection function is just a function of S, and the probability of early detection rises with the amount of surveillance and at a decreasing rate. So, unlike David's published paper, but like his current paper, we have a personal disutility of disease, but ours is much more simple than his, and not as good, I admit. We just assume that if your disease is found late, the health loss is kappa L. If your disease is caught early, your health loss is kappa E, and those are both greater than zero and ordered in a natural way. Everybody suffers personal disutility of surveillance. So the more surveillance, the higher that disutility. So this is going to enter negatively into utility. And we assume that actually is at an increasing rate. So in other words, having 2 colonoscopies in a year is worse than having 1 colonoscopy. It's more than twice as bad as having 1 colonoscopy in a year. And so how many people have had colonoscopies? Nobody wants to admit it. I didn't. I'm just trying to get you. Of course I've had one.
Virtual or
Pardon me?
regular or virtual?
Regular, yes. No, I looked at the false positive and false negative rates for the virtual and thought that I was pretty sure I didn't want to know that.
I had the virtual.
Okay, I might want to rethink that. Have a look at the false. Have a look at the sensitivity and specificity.
The result was virtual.
Yeah, right. Okay, so well, I once actually mentioned to my students about genetic tests and how basically nobody has had genetic tests in society, or not many people have had genetic tests in society. And this one student politely piped up, "I've had a genetic test," and I said, "Please don't tell us what it was for," because you might find people won't sit close to you, even though it would be a silly reaction, but people have silly reactions to these things. So, expected utility is quite straightforward. Here we don't have state-dependent utilities for the health and the unhealthy state, but we did a model where we did allow for that and it didn't make any difference to our qualitative results. So we left a simpler case here. So your utility is, in either state, is your income minus the total cost. So this would be the first best utility if you were accounting for the cost. It's not, later, when I talk about individual behavior, I'm going to assume that this total cost variable is just fixed. It doesn't depend on anything that the individual does, because the individual's in a pool of a large number of people, and you just pay the average cost, of course. In Canada, I think it's basically through your income tax, or the employer may pay for part of it. Used to pay for part of it. And then so you subtract the probability of disease, and then the probability of early detection is PED, so conditional on having disease. This is your expected cost. Conditional on early detection, this is the expected cost to your health loss, and this is the expected health loss if conditional on not getting the early detection, and then you subtract out the cost, the disutility of surveillance. And of course, you can affect this disutility of surveillance. I'm glad, Bernard, you mentioned that, because you can develop better technologies in the sense that they're less annoying. Okay? Colonoscopies aren't really painful, but they are annoying. The day before, you have to take more laxatives than you probably ever imagined you would ever take. And so it's a very unpleasant day that day. But a virtual colonoscopy, I don't think has that. And actually, there are some other advantages of a virtual colonoscopy. One of the costs of surveillance would be, I don't want you to feel too bad about your decision. One of the advantages of a virtual colonoscopy is there's no chance for perforation of the bowel. And that's actually a big side effect, because I was looking at some figures and I found that the cost of treating someone who's had their bowel perforated or nicked because of a colonoscopy gone wrong was as high as treating a person with third or fourth stage bowel cancer. So it's not something to be completely ignored.
And
I know
another advantage is that you can detect other cancers, like liver cancer or etc.
Oh yeah, so it's an overall scan kind of thing. Yeah. So, and you know, I mean, these are technological innovations which should be thought about when you realize that you could lower this cost, right, and get people more easily to have the test. And it's not just the direct benefits that we're talking about, but also the indirect benefits of getting people to take these tests at a more propitious rate in their lifetime. Okay, so the financial, and actually one of the problems of public health insurance versus private health insurance is that usually when we develop technologies in Canada, or we offer technologies in Canada and as well drugs, it's one size fits all, so you don't offer different alternatives. Before you know it, I'll be applying for a job in the United States so I can enter their healthcare system.
So this is going back to the motivation of public health insurance. So is that a common thing to think? How important is the role of health versus equity? What are we talking about?
How important is the role of
Health versus equity. And then what about these tests for wait lists? It's a big issue in Canada.
I don't know, I think that's a very good question. I actually have another paper I'm working on asking that very question. So the idea is that if you're in a public health system, you have one size fits all. And we're not modeling that as leading to wait times, but I think that's definitely part of the story. But it's also just lack of variety in what people can choose for the level of healthcare they want. And so, and also the other disadvantage of public healthcare is you have to have it paid for through taxation, which has deadweight losses associated with it, which are probably higher than the way that private sector costs get generated, even if they get generated through health insurance contracts with employers, which have their own deadweight costs. People are less inclined to leave their workplace for a better job if they can't take their health insurance with them, which they can't, and so on. So there's some efficiency benefits from the public system too, in a broader sense. So yes, I wrote down about. Unfortunately, I didn't put in the sensitivity and specificity rates of the virtual colonoscopy, which I found from the same source as this. So another way of thinking about low S and high S is that there are some tests, and one of the reasons for thinking about this was that Ontario used to actually offer this as the primary colon cancer screening technology, which is a FOBT, a fecal occult blood test. Okay, so you test for blood in fecal matter. And it's very cheap. The dish utility of the test is not as high as a colonoscopy, but it's not zero either. You have it's not a very accurate test. So if you have cancer, there's only a 40% chance that the test will reveal to you that you have cancer. If you don't have cancer, there's a 90% chance the test will say you don't have cancer. So in other words, the false positive rate is even pretty high, it's 10%. And so you're probably wondering, well, how can blood get into fecal matter if not through bowel cancer? Well, how many of you have ever had a bleeding hemorrhoid? Didn't trick you this time.
I want to sit alone tonight, didn't
So my guess is 10% of people have bleeding hemorrhoids when they do these tests. So, this test is not good at all at detecting polyps, and of course that's the gold standard for the test. Colonoscopy is because you find out you have polyps, you get rid of those polyps, and you essentially remove the risk of you don't eliminate it, but you really reduce the risk of bowel cancer a lot. Okay, so colonoscopy, as I mentioned, cost is higher, pretty accurate. If you have cancer, there's a 90% chance the colonoscopy will reveal that. It apparently they can distinguish between bleeding hemorrhoids and bowel cancer, and the specificity rate is 100%, so no false positives. And it also has a very high sensitivity for detecting polyps. But the dish utility is certainly higher, and I would argue that the main dish utility is the perforation risk. Although I don't know I would like to find out what fraction of colonoscopies end up with perforation. I know the doctor I talked to who did my colonoscopy assured me that he had never perforated anybody's bowel, and he had a big smile on his face, and I was thinking, okay, so I happen to know you do about 100 a year. So it's not a huge sample because he just started doing them, which also wasn't very reassuring. Nonetheless, I let him do it. So the information structure is the usual information structure. Before the genetic test, you just assume you have an average probability of risk, but you know that there's a certain probability that you'll be assigned to the high risk category, and a certain probability you'll be assigned to the low risk category if you take the genetic test. And then the probability tree works on from that. Now, one thing that is quite interesting is that when people are offered free genetic tests for a condition which they are, because of family history, reasonably likely to have, so consider the Huntington's disease gene. If you have an affected parent, there's a 50% chance you carry the Huntington's disease gene. And I have this on another slide, but I might not get to it. And so when people who had affected parents were offered free genetic tests, both in clinics in Vancouver and in a few different clinics in the UK, and this was admittedly back in 1990, I believe. I have it on a slide which you can look at your leisure. Only between 10 and 20% accepted the test. Now, in an expected utility framework, expected utility is linear in probabilities, and so the value of the test is nothing, unless in one test outcome you would change your life plan. And I'm pretty sure that for that test, for one of those test outcomes, almost everybody would change their life plan. It would change your savings rate, it would change your decision to have children, perhaps. It would change what occupation you go into. It presumably would change something, right? And as long as it changes something in your decision tree, then it has positive value. But yet, only 10 to 20% wanted that test. And so, I worried about this for a while, and then Ricard and I, along with Andreas, wrote a paper on this, and we assumed that we explained this possible outcome by saying, well, maybe people have ambiguity aversion about the results of the test. Okay, not ambiguity aversion about the probability of having the disease, but ambiguity aversion about the results of the test. And that sort of coincides with some other research that people have done which show that people fear tests like that. They fear the possibility that they'll be assigned a high-risk type, even though they realize the complement of being assigned a low-risk type is there for them, right? And if I don't get to the slides, you'll see some references I make to some nice literature on that. Okay. So I don't need to talk about this really, except to say that we have a parameter, epsilon, which we use to measure the predictive power of the genetic test, and that allows us to do some comparative statics. Okay, so I don't get that either. Okay, so from the privately optimal demand for surveillance from the point of view of an individual in a public healthcare system is that, well, I know that my level of surveillance isn't going to change the average total cost of providing healthcare, so I'm going to ignore the cost implications. And so the first order condition just comes from my utility function. So my choice of surveillance doesn't affect my income, so I don't have to worry about that part of the utility function. I just have to worry about the health part of the utility function. And so it's a pretty simple rule. The marginal value of reducing the probability of early detection is PED prime, and the advantage is the difference between the health cost of early versus late detection. And then you multiply that to get the full expected value of the surveillance by multiplying by the probability of disease. And so then that's just equal to the marginal cost of surveillance. And it's easy to show that you get this positive comparative static result, which one would expect, right? People with a higher probability of disease will want to choose a higher level of surveillance. And so that's what the curve looks like for expected utility as a function of surveillance. When you increase, for some with a higher probability of disease, that shifts their utility function down, but it also shifts the optimal point to the right. So how do we decide whether a genetic test will create private value or zero value or negative value? Well, as I just mentioned the setup to explain this. If you think about expected utility, it's linear in probabilities. So if the value function is convex in probabilities, then a mean preserving spread in the probabilities, which is what you get from a genetic test, will increase the value. Okay, mean preserving spreads are bad for concave functions. They're good for convex functions. And I'm in probability space, remember, not income space. So if you think about the expected utility function for the probability before you get the genetic test, which is rho naught, you take an optimal decision about surveillance and you generate this much expected utility. So that's 1 point on your utility line in probability space. If you maintain that level of surveillance and you increase the probability to 1, then of course you get less utility. If you keep that level of surveillance and you reduce the probability to 0, then of course your utility goes up because you're not going to get sick at all, and you know that ex ante. And as I vary the probabilities, I just know that the utility line is a straight line. But if you think about it, once I test positive, then I know that my old choice for surveillance is not optimal anymore. So I changed my optimal choice, and that's definitely going to raise my expected utility. If it wasn't going to raise my expected utility, I wouldn't have changed. And if I find out I'm a low-risk type, then I should change again my level of surveillance one way or another, lower. And so that will raise my expected utility conditional on this probability being happening. And so I can see that my utility function here is convex in probability space. So So I know that a mean preserving spread will increase expected utility. Okay, but remember, I'm not changing the cost here. So this person is, if I was changing the cost, this point would be higher, but this point would be lower. Right now, I wouldn't be able to say what's if I included the cost of treating disease and so on. So the welfare problem means I also have to figure out whether the total cost function of providing health care in equilibrium is convex in the probabilities. And it turns out that it's not obvious that it is convex or concave. And if you do the comparative statics to try to find out whether the derivative of this expression with respect to rho is, the second derivative is positive or negative, there are 6 terms in it, and 5 of them you can't sign. So this is why I was saying too, you can pretty quickly decide whether or not you want to go down this route with comparative statics in these cases. But that told me something. That told me that, okay, you're going to have to work hard on figuring this out. Now, I do believe that if you look at a case-by-case scenario, that probably with the help of clinicians and so on, you could figure out the shape of this total cost function. So it's not like I totally, it's not like I think we'll totally be in the dark, but it's something we have to figure out. And so the total cost functions, given the assumptions I made, are going to be convex in S. But I don't know whether the value functions will be convex or concave in rho. And so, I don't think I'll go through these graphs because I think what I've said is fairly straightforward. So, if the equilibrium total cost function, the value function, is a function of rho, is concave or linear, then individuals' welfare, even taking into account the cost aspect, will improve in equilibrium. But if that total cost function is strictly convex, then that could dominate the convexity. Where you don't want cost to be convex, right? You want value to be convex, but cost being convex means the mean preserving spread increases the average cost. So you don't want the cost function to be convex. So if the cost function is convex, then it's sort of a horse race between the effects of the convexity of the cost function and the convexity of the value function for individuals. Okay, so I don't think I will go through this. Okay, so maybe I'll go through a few of these points. So overuse of surveillance, let's face it, can be partially corrected by rationing or user fees for surveillance. The Canada Health Act, I think, takes a dim view of user fees, so that might not be an option in Canadian context. It depends on the country you're looking at. I've often wondered why we don't at least allow for small user fees in Canada for certain procedures, but instead we have doctors who try to be gatekeepers, right? So if you go to your doctor every 6 months and say you want another colonoscopy, he just simply won't order one, and you won't get it. On the other hand, you could just go in and see him and say, gee, I had a bunch of blood in my stool the other night. I'm really worried about that. Do you think I could get another colonoscopy? And your doctor probably would say yes. So he doesn't know whether you're telling the truth or not. So I'm not even sure it's very easy to ration people in this way. Your doctor could say, oh, well, just take a fecal occult blood test and we'll see. And then you could ask your spouse or partner to give you a bloody nose, and you know where I'm going with that, right? Or I'm pretty brave. I'm going to prick my finger right to the pin. I do it once in a while to test my blood sugar using my mother-in-law's equipment, just out of curiosity. So you can do that too. Underuse, though, is a real problem. As I was saying, can you really take people kicking and screaming to the colonoscopy clinic when they don't want one? But you might be able to encourage them somehow, I suppose. And one way would be to make the test more pleasant. Yeah, it wouldn't make sense to subsidize people because then everybody would say, well, I need a subsidy, I don't want another test. And of course, I've only modeled identical preferences. This could be super difficult when you allow for individuals having different preferences over their own perspective of the loss of utility from disease. And I think that's perfectly reasonable that we should imagine that is the case in the population. So once again, public healthcare systems, one size fits all, really can't deal with that issue. Okay, I think that's it. So I have to go to the top. Do I really have to? So maybe I have more time to talk about a few of the more interesting, what to me are the more interesting issues, which are not covered in a lot of models. So, when I started thinking about this presentation, I thought, well, maybe I won't present the model, but then David, you convinced me that since you said it, yeah, quite nicely, I could do it reasonably quickly. In fact, I was going to ask you to do it, but I was asking a bit much. So I just started thinking about, what are some of the basic questions I think about when I'm thinking about where I'm going to go next in this research about personalized medicine, and also, what should I put in my papers when I submit them to journals to say, well, what I'm saying here makes sense, but if you think about, I hope, within the model, but if you think about these other situations, it kind of weighs one way or the other on the general conclusions of what I've said. And so, the first question that has bugged me for a long time is how fast will the required science progress? Now, in the mid-90s, I joined a project that was sponsored by Genome Canada, and they gave me lots of money to give to other people, like students, and cover travel expenses to conferences. But they also made me present once a year at their annual conference, and most of the people presenting were scientists. I was the only economist. There was a mathematician who was writing bizarre equations on the board, no less bizarre than mine probably to most of the scientists, because they said they didn't understand math, which made me a little worried. And then, so I had to go to this conference every year. And I remember every year I would ask them, so how long does it take from discovery of a gene of a disease to a reasonable treatment option for the disease? And without fail, they said 5 to 7 years. So they picked a year somewhere in there. And I'm going, yeah, really? I thought that was a bit optimistic, and it is a bit optimistic. But, so I don't know how fast the science will progress. Maybe not fast enough for me to keep working this, but Stephen's going to tell us something about how fast the science progresses.
I guess on the top, you'll say it's coming way too fast. Just look at how many, if you look at what basically all drug discovery now is, it's all based on genetic evidence.
So you think it's coming too fast?
It's coming way too quickly because they're basically all exploiting the what they call the Orphan Drug Act.
Oh yeah, okay. And that scale, yes.
Probably tell you tomorrow. So.
Yeah.
They'll probably have too much innovation.
Right. Yeah, that's possible. But I'm thinking of, personalized medicine is the way my doctor works, right? And as David was saying, David Barty was saying, it's going to take some effort to get physicians to be geared up and so on. But no, that's an interesting point about the orphan drugs. I will look forward to that. And so, what are the roadblocks for institutional adoption outside of pharmaceuticals for personalized medicine? I thought about those. I wonder I've read about those. I haven't thought that much about it. I read about that. It's quite an interesting problem. Will patients embrace genetic testing? If patients won't embrace genetic testing, then there's not much point in designing a system which is based on the use of genetic tests. And certainly the evidence to date is that people are not very open to having genetic tests. But that could easily change with time as people get used to it. I have a slide about that. Will patients take effective decisions based on genetic information? So you get a genetic test result that suggests that you have a high predisposition to diabetes. Will you lose that, 3 or 4 stone? Well, not many British people in here. 3 or 4 let's say 5 or 10 kilograms you need to lose to avoid being at high risk of getting type 2 diabetes. And something to say about that from the literature, not my own research. And then how will private insurance contracts evolve? Now, right now in the United States in particular, there's, of course, the Affordable Care Act, which is restricting the use of certain information for insurance contracts. But something that Wanda and I are working on is we're thinking about, well, even that may be, even if that's the case, insurance companies can choose to have different styles, like different deductibles, different co-insurance rates, and you can do that within the set of medical treatments and surveillance procedures that you offer. So you might be able, by just gerrymandering the contract on different dimensions, to do a better job of cream skimming than your competitors. That could lead to some pretty active new sources of adverse selection for some companies, but positive profit results for others.
I think the big question from my mind is how do we get away from price discrimination for specific drug companies?
For drug companies.
Well, right now, so in the US, it's the same drug. If a certain gene, they can charge you a different price.
Oh, really? Well, that's very
So
interesting.
then it's called indication-based pricing. And
So if you're higher risk and value more, they'll charge you more?
because basically, because they can charge you based, because the drug company, your insurer will pay you up to the cost effectiveness ratio.
Well, that's very interesting.
And I think that to me is the bigger.
Well, I was just saying that's so different in Canada in the sense that once the market is chopped up into all the little orphan diseases, this is the only treatment available for X disease, then the province has very little power to negotiate lower prices with.
Yeah, compared to other
So-
more sort of standard medical problems. Yeah, I have looked a bit into this literature, and one of our students did a study on orphan diseases and pharmaceutical research. And now that I think about it, I think he came up with a result that suggested over investment. I mean, if you send me one of your papers, that would trigger me.
Get cited, Google Scholar score goes up.
Okay, yeah. I'll try. I'll send it on to him. I'm not sure he's published it yet. So, what should economists focus on? And so how fast the required science will progress, and I observe boosters and cynics, okay, and everything in between. So, but my early view from this came from a book in 1981, which I read not too long after 1981, but I didn't read it hot off the press or anything. And it's very interesting, for me at least, to revisit this. And it's called Genetic Prophecy Beyond the Double Helix. But they were quite cautious in their suggestions about what might happen. But actually what they said might happen seems to be happening, right? And it's taken a long time, but much of what they said could be the case has turned out to be the case, like genetic discoveries that some people find it harder to quit smoking than others due to genes, due to their genetic background. So when we try to say, well, smoking is a realization of moral hazard, and we should really, punish people who smoke. Well, the fact of the matter is, the reason they smoke is maybe like many young kids, they smoked just for the hell of it, and then they have this genetic trait that makes it very hard for them to give up smoking. So it's not actually just behavior, it's also genetics. It's hardwired to some extent, at least. And so I've thought about models which take those two things into account and then try to embed that in some of this literature on fairness, on responsibility, option luck, group luck sort of thing, which I'm hoping to pursue. So that's one area to look into the future for economists who like that literature. Not everybody likes that literature. So Leroy Hood is a real booster. I heard him give a talk at University of Waterloo quite a while ago. He's 80 years old now. I looked him up on the internet, and he's still running this personal medicine institute, or personalized medicine institute. And it was quite a while ago that he said everyone will have their entire genome sequenced within 10 years. And he said that, I think, more than 10 years ago. And when I read that, I thought, everyone, who's he including in everyone? Maybe everyone in the United States who has a high-quality health insurance program, or wasn't really sure who he meant by everyone. That's probably what he meant. But this hasn't happened yet. Now, I went back to his website just this morning just to see what I went to his Wikipedia. I went to Wikipedia, looked him up on Wikipedia, and they said that he's now claiming well, they didn't say he's now claiming, they just said he is claiming that by the mid-2020s, everybody will have their entire genome sequenced. And yeah, so he just shifts it up every 10 years, I guess. But you know, what's interesting is that the sequencing part of the human genome project actually happened ahead of predicted schedule. So the problem isn't in sequencing genes. People have been more effective at doing that than they thought, and now it's very, very cheap. The problem is understanding them. Because you know, any pair of individuals differ by 6 million nucleotides in their DNA, plus they face different environments. And so how much data do you need to understand the relationship between genes and other genes and the environment and appropriate treatment for diseases and also just the risk? So, and I want to emphasize that even many simple monogenetic diseases are more complicated, at least than I thought. So Huntington's disease has always been sort of classic, simple, monogenetic disease. If you have the gene, you're definitely going to get Huntington's disease. If you don't have the gene, you're definitely not going to get Huntington's disease. But age of onset is highly variable, even for someone with precisely the same variant of the Huntington's disease gene. So what causes Huntington's disease is too many CAG repeats in the gene, which is supposed to produce the function, which if it functions properly, you don't get Huntington's disease. But if the protein, if it functions properly, you don't get Huntington's disease. But if it functions improperly, you do get Huntington's disease. And you know, most common from the scatter diagram suggests that most people have somewhere between 40 and who do get Huntington's disease have somewhere between 40 and 60 repeats. But within at any number of repeats, even if you know the number of repeats, there's a huge variation in age of onset. So you know, that's obviously an important consideration for long-term care insurance. So obviously there are many other important factors which determine susceptibility to Huntington's disease, at least from the point of view of age of onset, which are going to be important to people. So there's still a lot more to learn. It could be other genes which protect against early onset, given conditional on the OCEG, or it could be environmental causes. And so it would be nice if research could tell us what that all is. If it's environmental causes, and that could be extremely useful for prevention, or at least avoiding early onset. A more cynical view, if you're interested in behavioral genetics, I really like this book by Michael Rutter. I looked him up on Google Scholar and so on. He's a highly respected person in this field, and he wrote this very readable book about genes and behavior. And even though it's more than 10 years old, he's saying things that the cynics are still saying. We're just starting to learn what's going on in terms of causal processes, and that it's going to be a long path. I really like this paper, which in my view has a nice middle measured viewpoint. And so if you're interested, you can look that up. And I'm not going to go through the quotes here, except to say that, well, they're not so sure that it's going to be an easy road to hoe to get to effective understanding of a lot of, except for a lot of complex or multi-genetic diseases. I really like their last point here, though. They note that over a 5-year period, not too long ago, there were almost 50,000 scientific articles on human genomics published. Only 520 or so were clinical trials, and of those, 52 reviews designed to inform clinical policy. So this is what I meant when I said we need more examples. We need to see just how is this information being used at the clinical level, and is it being used effectively, and what do we need to understand to do it better. One thing that I find surprising is that some economists are working on developing polygenic scores to try to see how genetics affects lifetime outcomes such as education, wealth, and so on. And so I think this, well, at least one of the directors of this working group, Human Capital and Economic Opportunity Global Working Group, is James Heckman. And there's some interesting papers online there. If you just search according to with the word genetic in it, you'll see a bunch of papers that come up. One that I found particularly interesting is this one by Barth and other people. And they explain reasonably nicely what a polygenic score is. At least I found it reasonably nice. Still a little in the dark about how they do it. But you basically look at each individual in a genome-wide association study. They look at each individual, and they identify, well, the study identifies a set of single nucleotide polymorphisms, that is a change in one of the base pairs in your DNA. And they just look at all those without thinking too hard about what they mean, without thinking at all about what they mean. And then you produce a score which helps you predict life outcomes, such as education level or wealth. And then you can take one of these polygenic scores and apply it to a different economic phenomenon and so on. And it's actually, I mean, it doesn't, these things don't explain 50% of variation in a population, but it explains enough to make me think maybe the science is progressing faster than I think. Although there's no real understanding of causality or anything from these sorts of studies, I don't think. Also, I certainly think there's room for optimism about personalized medicine, at least for specific genetic diseases, right? PKU is something that has been known for a long time, is a genetic disease. It's due to a recessive gene. It's the lack of a liver enzyme. If it's not caught early, it can have disastrous effects, but again, there are many different variants of this gene. Some lead to more penetrance than others. And the nice thing about this is if you identify the disease early enough, it's easily treated with a restricted diet. So the diet has to be low on proteins and some other factors. And I think people are learning a lot more about Alzheimer's and the relationship with APO genes and so on, which at least is predictive about early onset Alzheimer's and can help people make better life decisions. Make getting insurance harder because it creates more adverse selection problems. The BRCA1/2 tests are an interesting example, which I think people could use to justify certain assumptions in their models and so on. So if you're interested in fairly recent risk factors by age, you can go to the first website I mentioned. The second website I mentioned discusses came out. This was recorded in 2016. Talks about the so-called Angelina Jolie effect. She discovered that she had one of these breast cancer genes and had a double mastectomy and a oophorectomy. She had her ovaries removed too, I believe, although she never talked about that. But someone said that she did also. Somebody who hopefully wasn't just lying about it. And she mentioned that she reduced her lifetime risk for getting breast cancer from 87%, I think she took the higher number there, 87 or 85% to 5%. And I've seen studies which show that this is actually quite an effective treatment to avoid breast cancer. And but the study I saw was only used 5-year remission period, so it's not something that I would rely on too heavily yet. I mean, we have to wait longer to see how these women's lives play out. And something which shows how quickly things can change. The last point here refers to an article reporting on some scientific research which showed that even if you do have the breast cancer gene, you may have some other protective genes which lower your risk, and so might sway people, at least according to clinical practice, about taking such an extreme measure as Angelina Jolie did. And the study suggested that rather than 50% of people finding out they have breast cancer and having radical mastectomies, maybe only 36% should. But that's clinical advice, and the advice any individual is going to follow has to be personal, of course. Roadblocks for institutional adoption. Well, one part of this problem is what David Barty talked about. You've got to get doctors prepared to use this information. You have to train them. Many doctors don't really understand probabilities. They don't understand conditional probabilities. So it's very hard for them to really follow through on personalized medicine. My guess is that since, at least in Canada, doctors often work in clinics, that one could imagine that there will be a clinic for genetic diseases where there would be a few people trained in a community. You don't have to train every doctor, right? And the doctors can just write out the prescriptions or look at the other symptoms which make sense to existing doctors. A big problem is privacy. So I wrote a paper recently just on this third-party. I wrote it with my wife, Maureen Durnan, on third-party sharing of genetic information, and she found some really interesting examples where organizations which we actually don't expect to give away your data for free do that, thinking that they're furthering science. But then, for example, the National Health Service in the UK in 2015 gifted 1.6 million patient records to Google's DeepMind, which is trying to develop a data bank of genetic information, trying to relate it to disease outcomes. And they forgot to take out, they stripped off people's names, but they forgot to strip off postal codes. Now in the UK, postal codes represent a small group of people, just like in Ontario or anywhere in Canada. So with a little extra information, people were feeling that their privacy was certainly compromised. And of course, data hacking almost seems commonplace. We see things about that every day. Now, economists can say something about this. I really like the paper by Miller and Tucker, who asked the question whether privacy regulation promotes or might actually hinder the use of genetic information, because although if you give good protection to individuals, to consumers, they're more likely to get genetic tests and take them to their doctor or have their doctor initiate them. But if they know their rights, then if there is a leak, then they're more likely to sue the organization which leaked the information. And so they found that institutions were quite worried about that happening as a result of privacy regulation, which was supposed to be helpful. And well, it's helpful to consumers, but not necessarily helpful to the market as a whole. And so there's lots of examples. So if you want to see some of the examples, you can just look at the reference I mentioned in the notes. When I mentioned, will patients embrace genetic testing, I mentioned this fairly old study and done in 2000, but I was really surprised by this study in 2011, which demonstrated that only 30% of newly diagnosed early onset breast cancer patients chose to have a genetic test to guide treatment. So these are people who already had the disease. It's not just people who have family history of the disease. And this could help with their treatment, not just further prevention. And they still people are not so likely to get this new information. So I think we need to understand better what the reasons are. Are they worried about it being used in other contexts, life insurance, employment? Are people just nervous about it? Just what is the source here? Economists can model this as Ricard and Andreas and I did, or look maybe in the psychological literature a bit more to try to understand. Will patients take effective decisions based on genetic information? The answer appears to be no, albeit with exceptions. Angelina Jolie. And I forgot to mention, after Angelina Jolie reported to the newspapers what she did, the testing rates for BRCA1 in the UK rose almost immediately for a 2-week period by 67%. And even 4 months later, the testing rate was still about 35% higher. So this can have an effect on how people view genetic tests. So we need to get more celebrities to do this. You know, I admitted to you that I'd had colonoscopies. That's that was hard for me to do. but people are just a little more open about it. I can remember my parents' generation; they would never talk about stuff like that to their friends. But nowadays, people do seem much more likely to discuss these things. So I do think things are changing, and it could easily, well, it could possibly change in this context too.
5 minutes.
Oh, 5 minutes, sorry. So Handel and Kolstad have noticed that people in the United States, well, they're not the only ones, of course, you'd have to be living under a barrel, have noticed that people in the United States take bad health decisions, right? Even when the costs are largely borne on them, or to a large extent, the cost to individuals for taking bad health decisions. I think smoking is the best example, probably, of people who take bad health decisions. They're trying to look for new ways to get people to take better health decisions. And this is going to be especially important if we get a bunch of genetic information, because we're going to want to be able to say, okay, we want you to have a colonoscopy every 2 years. We want you to have a colonoscopy every 6 years, you every 10 years. We want you to get more exercise. We want you to do this, that sort of thing. Well, it was David Barty was mentioning over drinks the other night while we were smoking a couple cigarettes. Well, no, we weren't smoking. Mentioned that pretty soon there are going to be such advanced wearables and other IT tools that all this information will be able to be recorded. So at least it won't be hidden information anymore. It's not clear that will lead people to stop. I mean, smoking is not hidden information anyway. You just have to look at a person's lungs with an X-ray. But maybe that will help, and maybe financial incentives will help too. A lot of companies are getting programs together to combine the use of wearables with results to give people reductions on their health insurance contributions, or just give them money if they achieve certain targets. My worry about that is the people that will do the exercise because they have the wearables would actually do the exercise anyway, and the people who don't want to do the exercise just don't join the wearables program. Okay, so the last point that I would like to make is just that although even in the United States, where there's now quite a few restrictions on private health insurance, there's still a lot of variation as to what plans look like. So I saw a nice study, and unfortunately I didn't mention it here. Did I mention it on this page? I know I didn't mention this study because it's not a working paper yet, and I don't think I got the paper and said do not quote, so I'm quoting it, but I'm not telling you who did it. And this is nothing. This is not really special information. But under current regulations, plans in the U.S. under the Affordable Care Act vary by how much the actuarial value of cost must be covered. So in other words, how high the coverage level is in actuarial terms. And bronze is only 60%, silver 70%, gold 80%, platinum 90%, but there is a maximum out-of-pocket expense on these. But you can vary the coinsurance rate and the deductible on different aspects of the insurance, on different treatments, aspects of the insurance policy. So there's a huge variation. And there's even substantial variation in cost of plans within a metal tier. And so, and I also think that direct-to-consumer genetic tests will exacerbate problems for the private insurance market, because people will just go and get a genetic test, and it's their private information, it's not their health record. But those genetic tests those direct-to-consumer genetic tests so far are pretty poor. I read an article which said that some people sent in their dog's DNA, and it's easy to get dog saliva, believe me. And so they sent their dog's DNA in, and they got a report explaining how they should change their diet and so forth to improve their life, and they didn't say for Bowser at the bottom, they were treated like a human being. So I'm not sure what kind of genetic test they're doing.
And we don't have this for human because the FDA, whatever, has not approved that.
Pardon me?
We don't have the similar test for humans because there is a regulatory hurdle. There is a
No, they thought it was a human. They sent a DNA test and they attributed it to a human being, but it was saliva from their dog.
Oh, okay.
And so, you know, the lab didn't even notice that it wasn't human DNA. And I know we're not as far away from dogs as you might think with our DNA. So that, you know, that's a bit disconcerting that they didn't pick that up. So it's reasonable to question the quality of those tests in general. So I finished.
So, time for one quick question.
You forgot criminals and DNA.
Oh yeah, actually, I had a line in there about criminals and DNA, and I took it out.
Okay.
Well, the line was a reference to the fact that a taxi driver was about a story where a taxi driver was deemed responsible for a murder based on DNA evidence. I'm not sure why they took his DNA evidence, but they took some clothing of his and they discovered that he had DNA of the person who was who was the actual murderer, or at least, yeah, suspected to be murdered. It turned out that it just been that the murderer was in his taxi cab, and some of his DNA got on his clothing, and so it was a complete schmozzle, yeah. And it can or sperm DNA can apparently survive through a washing machine, so you might want to worry about that.
Other reasons.
Surprising. Anyway.
That's an interesting way to finish the first game.
Yeah. Maybe one remark that I 3 or 4 years ago I sat a governing commission that studied personalized medicine. We made recommendations. One recommendation we made, I can't see it there, but we made several recommendations about privacy, insurance, and so on. One recommendation we made was about improving doctors' training on the use of genetic information, for instance. It relates to a comment that Suzanne made this morning about protocol and so on.
Well, yeah, I think even if you have genetic counselors who are really
Genetic counselors,
understanding what's going on, the doctors need to know something, right?
That's right.
Because they need to know when to send someone to a genetic counselor.
Exactly.
And they need to
Exactly.
interact with the genetic counselor to understand what's
That's
going on,
exactly.
to make a healthcare plan. So, yeah, I think that's part of the cost that will have to happen.
That's right, that's right. And you mentioned also the fact that they're not necessarily very familiar with probabilistic data.
Yeah.
That to do with probability.
And we now know from David that they can't write either, so whatever they can do.
In fact, most of physicians, they don't manage the concept of conditional probability. They think on average, and it's difficult. It's one background that we have to try to improve.
And based on updating.
Yeah.
No, so in a way, it's understandable. I mean, my fourth-year undergraduates still struggle with basic algebra. So.
We finish on a very reassuring note. Thank you very much. Thanks, Mark.